Hi everyone, and I'm delighted to welcome you to this HDR UK Wales webinar on inflammation and immunity. My name's Gwyn Davis. I'm a Professor of Respiratory Medicine here at Swansea, and I lead for Wales on the driver programme in inflammation and immunity. So I'm delighted to introduce Dr. Ting today. Ting is a Chancellor's Fellow from the University of Edinburgh. She's an epidemiologist with expertise in infectious diseases and in global health. And Ting's particularly interested in respiratory viral infections, including RSV and COVID-19. And I know Ting is currently focusing on looking at the impact of RSV vaccination programmes on winter pressures on the NHS. So I'm looking very much, looking forward, Ting, to your talk. Thank you.
Thank you, Gwyn. Thank you today for having me. And as Gwyn introduced, so I'm a Chancellor Fellow based at University of Edinburgh. My background is infectious disease epidemiology. So today is my huge honor to talk a little bit about my work, particularly focusing on using administrative and health data in inflammatory research. And I will be giving a couple of examples, including the RSV work, including the winter pressure work, as the user cases here about how we have been using these administrative and health data in those research. So a little bit about myself or about my team. So we have been doing a lot of work in respiratory disease epidemiology, and including the RSV, influenza, and the COVID-19. And we have been involved in a few projects, particularly focusing on the pandemic preparedness. For example, how we are going to generate, how we are going to produce a framework focusing on public health response to any pathogen with epidemic or pandemic potential. So all this work will be all relying on the medical records, and either locally, nationally, or from the global partners. For example, we've been using a lot of administrative and health data from from Scotland and from the other 3 UK nations to look at COVID-19 vaccine, how effectiveness, what is the effectiveness, safety, and uptake, using the national electronic health records. And working closely with the global partners, we've been collecting the medical records from their sides in order to understand, for example, disease burden at the global level, at the regional level, as well as at the national level. But today I'm going to particularly focusing on how we are going to use the UK data, using the administrative and health data to answer those research questions, and particularly focusing on Scotland. And so I will go through a few user cases very quickly, focusing on like RSV, looking at the impact, the association from early exposure to RSV, how that has been affecting the childhood asthma development by using the national linked data sets. And then I will go into a little bit details about a project we're currently coordinating, trying to understand the RSV vaccine performance from effectiveness, safety, uptake, and cost effectiveness of the vaccine programs. And then the last user case I'll briefly mention will be focusing on the winter respiratory pressure, about looking. Sorry, did someone say something? And so been looking at the role of common respiratory pathogens, how that has been playing a role in contributing to the NHS pressure, particularly during the winter time period due to their seasonal patterns. So before I dip into the first 2 user cases focusing on RSV, maybe I will talk a little bit about what is RSV for those who are not familiar with this respiratory pathogen. So RSV is a virus that is easily spread throughout the community, and basically everyone will get infected with the RSV at some point in their lives, usually before they turn 2 years old. RSV disease is often mild like a cold, but can be quite severe or quite deadly for infants or older adults, particularly with those with the comorbidities. And the transmission of RSV can occur through sneezing, coughing, and transference from contaminated surfaces. And the repeated infections from RSV can happen over a lifespan, since the infections induce only partial immunity. So although any child can get severely ill or hospitalized because of RSV, children are at highest risk if they are under 6 months old or have comorbidities like heart and lung diseases and prematurity, or live in socioeconomically disadvantaged areas. So the RSV usually also infect the respiratory epithelial cells of the upper and lower respiratory system and triggers a host inflammatory response. And the symptoms usually happen between 3 and 5 days after the infection. The symptoms can last up to 10 days, and the viral shedding can occur for like up to 2 weeks. And so the infection in children is typically mild with upper respiratory symptoms, similar to common cold, but it can be much more serious if it becomes the lower respiratory infection. So there has been a lot of studies on RSV disease burden at the global level, and in the most recent study has shown that in 2019, RSV has been responsible for about 33 million episodes of acute lower respiratory infections at the global level, and about 10%, actually over 10% of them require hospitalization, and over 100,000 of them actually die from RSV. And all this happened within the first 5 years old. And the majority disease burden actually has been observed to happen within the first 6 months old, which accounts for nearly 20% of the whole under 5 children population infected with RSV. So now we start with our first user case, looking at the association between early life exposure to RSV and the childhood asthma development, and how we're going to use the routinely collected electronic health records data from Scotland or from the other UK nations to answer this question. So we've been looking at this, when looking at this research question, we start with Scotland. So we've been requesting data in the last 20 years within Scotland to hopefully to curate a data set of RSV at different severity levels in children under 5 years old. So that will include, we've been looking at the primary care data, we've been looking at the hospital admission data, we've been looking at the laboratory testing data, and we'll be looking at the prescription data as well as the mortality data, and be able to link them together at the national-wide and to look at this research question. Similarly, we want to look at how this early exposure to RSV infection in infants and the association from it to the later life childhood asthma development or recurrent wheeze. So we'll be looking at the same, we'll be linking the data from after a couple of years, follow up the individuals who had or had not RSV exposure in early life, and then look at what happens in their 5 or 6 years later, when they are more than 5 years old, when the asthma diagnosis was more reliable, and we'll be able to observe whether there might be some association between RSV and asthma, and whether we can look at that in very granular data, look at the impact from RSV severity on this association, as well as the age when these infants got infected with RSV, how that is affecting the association. So broadly, as I mentioned in the earlier slide, we're going to query this RSV data set by looking at the electronic health records data in both primary care and secondary care. And I'll be defining RSV at different severity levels with the mild RSV as well as to the moderate RSV, who And for those who require hospital admissions, they'll be classified as severe RSV, and for those with very poor outcome, define them as very severe RSV. So then by looking at the whole population within Scotland, so the coverage of the data set will be over 95%. So be able to look at people, majority of the people within Scotland, looking into their electronic health records and looking at this cohort in the last 20 years. We define them as exposure group and unexposure group, depending on when they got infected with the RSV, and see how that has been affecting the asthma development 5 years later or even longer term. And we'll be able to look at the RSV severity when they were affected for the very first time, whether it was mild or severe or very severe, and we'll be able to look at the age when these infants got infected with RSV and see whether that has an impact on the association. So that is the beauty of using the administrative and health data, which will allow us to look at like 20-year data to observe whether there are any potential associations between the early exposure to RSV infection and childhood asthma development. If we are going to do a clinical trials, it's going to be enormously expensive, and for 20-year follow-up, it's going to be a really big project. But however, by using the observational data retrospectively, we'll be able to do this quite efficiently by looking at 20-year data and to trying to identify whether there are any associations we can observe from those from this massive data set. So we have requests to use many data sources, starting from the primary care data, which we requested from Datalog, which covers Southeast Lothian of Scotland. And then we also request other data, for example, the birth record data, the inpatient data, maternal data, and as well as the laboratory testing data, prescription data, and all the way to the mortality data from Scotland to look at these at different severity level from different data sources. And all the data sets will be linked using a CHI number, Community Health Index number, which will allow us to look at multiple data sources for the same research question. So basically, this figure summarized what I mentioned earlier about looking at different data sources from different for different variables, which will allow us to look at this research question, and we'll be analyzing the data in the National Safe Haven, and for the data output, we'll be able to we'll be able to look at those this research question in granular approach, looking at how we are going to observe this association in different subgroups by different parameters. For example, by the RSV severity, by the age of being affected with the RSV, or by socioeconomic status. So that will allow us to produce a lot of outputs by different variables of interest. Then this will be the second user case of using the administrative data and health data to look at how powerful the analysis is going to, how robust the analysis is to answer those important questions, which will fit into the vaccination strategies. So, for example, right now we all are very excited about the RSV vaccines, which are rolled out in Scotland from August onwards, August 2024 onwards, and in the other 3 UK nations from September onwards. And the RSV vaccine has been offered to both pregnant women and older adults at the same time. And we want to understand whether at the population level, whether we can collect some real world evidence to observe the vaccine effectiveness, safety, and uptake for both pregnant women and older adults. And we already have the data infrastructure set up from the COVID work, where we were able to look at the multi-nation electronic health records data, and we put which will allow us to run the meta-analysis across 4 UK nation. So we're going to take similar approach using the existing data infrastructure we set up for the COVID-19 work to look at the RSV vaccine. So particularly for example, safety, there might be some safety signals which might be very rare and we wouldn't be able to look at it using just one nation data or observed from the clinical trials. But by combining 4 UK nation data, will make this analysis more reliable and more robust to look at those particularly very rare safety signals. So this piece of work, we just started, so I don't have any data to present at the moment, but happy to have another chat for anyone who is interested in having a conversation on this or potentially interested in this piece of work. And then it came down to my third user case on the winter respiratory pressure. So similarly, this piece of work we've been using Scotland administrative and health data to trying to characterize and identify risk factors for acute respiratory infections which require hospital admission during the winter time period in Scotland. The reason why we want to look at this is because NHS is under huge pressure, and particularly during the winter time period, because of the seasonality of those common respiratory infections, which have placed the NHS under enormous pressure regarding for example, the hospital beds, regarding the personnel and the staff members required to attend to the patients, and we want to have a look at this, understand who is most vulnerable. For example, who is most vulnerable from being infected from common respiratory infections, and whether there are any early interventions or management strategies we can place in advance to mitigate these, which will help to mitigate the NHS winter pressure. So, this piece of work has been published earlier this year. So we've been using similarly the whole Scotland data from the primary care records from the vaccination records, as well as looking at their potential outcomes, hospital admission data, the ICU admission data, and the mortality data, to create this cohort study, which allow us to look at the population level, what factors, what predictors have been contributing to these acute respiratory infections during the winter time period. And we found that people who live in the more deprived areas, or smaller children or older adults, are mostly at higher risk from being infected of acute respiratory infections, which have contributed substantially to the NHS winter pressure, in addition to those with underlying health conditions or with prior emergency admissions. So we observed from the data from the cohort we created within one winter season, we have observed very clearly about the pattern of the instance number of cases admitted to the hospitals due to acute respiratory infections over time, and see that there has been a peak during the winter time. And when we populated compared to other conditions admitted to the hospitals during the same time period, we can see that for example, when people were admitted to hospitals due to cancer or due to cardiac diseases or trauma, we can see quite consistent number of admissions across those conditions. However, for respiratory conditions here, which is the blue color, can see a peak during the winter time. And this is exactly why we want to evaluate, understand the winter respiratory pressure, and hopefully I'll be able to generate some evidence for the early interventions. So based on this published piece of work, we hope to generate in future, we hope to develop and validate an algorithm to predict individuals who would require unscheduled care, for example, out of hours visit, NE visit, or who might have poor health outcome and in the hospitals due to common respiratory infections, including RSV. So this is ongoing, and one of my PhD students is leading this piece of work. So we will start with using the Scotland National Linked data, and we hope to use the England data to validate the algorithm, and before we want to implement it in NHS. Apologies. So yeah, I think that's everything from me, and feel free to ask me any questions about any of my studies or any of the future potential work. Thank you.
Thanks very much, Ting. That was that was a great talk, really interesting. So I'll ask people to put any questions in the Q&A, please, rather than the chat, or put your hand up. I'll kick off with a question on the vaccination programme, Ting. So obviously that's a really important piece of work you're looking at. You're going to focus on severe admissions and deaths, and I just wondered if you could expand a little bit on what you're looking at. So you're obviously interested in the whole population level here, but I presume you're going to hone in, on those risk populations in particular where you'd expect to have the greatest impact in terms of the vaccination programme. John, would you like to just expand a little bit on what you're going to be looking at in terms of outcomes and so on?
Absolutely. So so for the RSV vaccination evaluation program, and there will be, I know that each public health agencies will be doing a lot of work trying to understand the vaccine's effectiveness, safety, and uptake within each UK nation. And my work is more at the 4 UK nation level, whether we can do the meta-analysis, combining the data from each nation, and which will allow us to have more robust estimate across many more robust estimate across many research questions. For example, particularly on the vaccine safety, which be able to have more. So we'll be able to, I think the key point I want to make that with 4-nation approach, or potentially even 5-nation, we are also talking to Ireland at the moment. The main point is that we'll be able to have more extensive data and more research level questions, investigation of like regional variation in effects, and also hoping we hope that to set up a pipeline for repeating similar analysis much more easier in future studies. So that is the purpose here, and the outcome we want to achieve, apart from doing the research project of evaluating this vaccine program across 4 or 5 nations, but also to set up pipeline for future work doing similar analysis.
Thanks very much. So I can't see any questions in the Q&A yet, so so please raise your hand as well. Oh, Alicia?
We've got a question from Pia.
Excellent, thank you. Pia?
Yeah, hi Ting, that was a brilliant talk, and I've done a lot of work on RSV in my career, particularly using Scottish data, so it sounds fantastic what you're planning. And I've cited your systematic reviews many times. So I was just going to ask you, so obviously, as you were saying, the association between early life RSV infection and wheeze and asthma has been described many times, particularly for children who've been admitted to hospital with RSV. So but the problem is obviously, like, you don't know if it's causal, because it could just be the children with the weak lungs. So how have you thought, what methods are you planning to use to sort of get at that causal question, because that's always something we get asked by reviewers.
Yeah, I think that's a great question, and that question has been, I think, that question has been, a lot of people probably has been thinking about that question for many years, and I think it's not easy to answer that, but we've been thinking So particularly for 2 levels. So the first level, during the first part of the pandemic, we observed the reduced exposure or postponed exposure to RSV in early life for children. So I'm hoping to, looking at the Scottish data retrospectively, we'll be able to capture that as natural experiment and to look at what happens to those infants with reduced or postponed exposure to RSV in the early life, whether we're going to observe a different pattern, a different instance or epidemiology of childhood asthma development 5 years later. So that is one thing I hope to study design, a study cohort I hope to add to investigate in order to answer this research question. Apart from the observational study, look at the association, whether we can tease out the causality. But again, there are many factors around that, so I wouldn't say it's we're going to be able to answer the question saying a yes or no. The asthma was caused by RSV or not, but from a more natural experiment, probably providing more evidence around that. And the second thing I want to mention is that with the RSV vaccines rollout, again, this will be run as a natural experiment to see now with the RSV maternal vaccine rollout to pregnant women, and we're going to observe a reduced incidence rate of our RSV within the first 6 months of babies, and whether after 5 years' time, whether we're going to observe similar whether we're going to observe a different incidence rate of asthma within those children. And I know a few clinical trials are looking at this research question as well, including Harmony. But I think they are still collecting the data to follow up the children, to follow up the babies until they're old enough to be diagnosed with asthma or not. And so there are currently no evidence on that, but I know a lot of parties are really interested in this, including the clinical trials. And obviously for the using the national health records data, I'll be very keen to look at that as well in a couple of years, using following these natural experiments after the vaccines roll out. Thank you.
Thanks. Did you have a question, Sinead?
No, I was only going to say about as the vaccines roll out slowly, surely that's an opportunity to be able to look at possible
yes, absolutely,
natural experiment methods and causal. So yeah, no, that was all I was going to say.
I can't see any other hands. So yeah, Pia, that was a really interesting question, and I was thinking about that myself. So just to briefly follow up on that, Ting, I was thinking about all the factors, the complex interactions that you could have to cause asthma, including, atopy and pollution and so on. Yeah. And with, you might plan to look at some of those. For example, could you look at the interaction between RSV and atopic status, for example? And, do you think in the future, I guess we might potentially be able to look at quite complex interactions to sort of get to the root of, to be able to sort of, look at risk in a bit more detail?
Yeah, absolutely. Yes. Yeah, we're mapping the deck at the moment and it's massive.
So I think that's all the questions thanks very much, Ting. That was really interesting. I'm going to hand over to Sinead for the second part of the session now. Thank you.
Thanks very much. And I'm really, really pleased to welcome Pia here, who's Professor of Epidemiology in UCL and in the Great Ormond Street Institute of Health, Child Health. She's co-lead of the Applied Child Health Informatics and works very much with schools. And so I'm really, really pleased to introduce Pia here. I'll just hand over.
For inviting me. I'm delighted to be here. So I lead the Environmental Child Health Research Group at UCL Institute of Child Health. And I'm going to talk to you about how we are setting up a new linked national data resource for environmental child health research in England. So I'm sorry to be sort of negative. A lot of people were very negative yesterday, and I'm sorry to keep it negative, but we are, as you know, facing an unprecedented environmental crisis. So globally, we have a changing pollution landscape where traditional forms of pollution from solid fuel burning and water pollution is decreasing, but then air pollution from traffic and industry and also chemical pollution is increasing. And of course, our addiction to burning fossil fuels is driving climate change. And related to both of these factors is large-scale biodiversity loss. So these things, pollution, climate change and biodiversity loss are already affecting health globally. And children will really bear the brunt of these problems. So it's basically children are going to bear the brunt of the problems from people who are adults now in our generation. We have caused them. Trying to get there. So everyone is really, as you know, again, affected by these environmental crises. And here are some recent UK headlines. And as I said earlier, so the WHO estimates that 90% of the burden of climate change will be borne by children under 5, even though they constitute 10% of the global population. So I feel that we as researchers really have to ensure that these health and also sort of education and cognitive development effects of climate change are documented and monitored. And we also need to evaluate whether our adaptation and mitigation measures are working to protect and support children. And then, of course, it's not just sort of our physical environment that is changing, but political decisions over the last 45 years in the UK have meant that we now find ourselves in housing crisis, with families with young children in particular who live in rental properties are really badly hit by precarious housing, mould, damp and cold, drafty homes. And similarly, because of 15 years of austerity policies in the UK, there have been many changes to local services, including many services that children use, so childcare facilities in particular, and also libraries. So I really think that there's a massive need to monitor how all these changes to both the children's sort of physical and social environments in the local environment where children live will impact children's health and education as they grow up. And so that's why we are setting up the Kids Environment and Health cohort, which will be a new national linked administrative data resource for research into environmental impacts on children's health and education in England. And England is a huge country, so the cohort will hold data on over 11 million children who were born in England since 2006. And to be honest, this will allow us to do in England what you've been doing in Wales for many years. And so I and my team, we're really learning a lot from you, and particularly from working with Sinead and Rich and Lucy and colleagues. And we're really delighted about that. But this is we're funded by Administrative Data Research UK with additional funding from Health Data Research UK. And this is our logo, which has been, we've had help to design the logo by the Young People's Advisory Group at Great Ormond Street Hospital. And they've also helped us to come up with the name for the cohort. So what data? It's a data seminar, so what data will be in the cohort? So the spine will be birth registration. So like I said, it will be live and all live and stillbirths in England since 2006 onwards. And they will be linked to birth notifications, which are like maternity records, and it holds information on gestational age and ethnicity of the baby in particular, and then also linked death registration. So they're held by Office of National Statistics. And then children will be follow up using longitudinal linked administrative data, so hospital records, accident and emergency attendances and hospital admissions, community dispensed medicines, community mental health data, and also education data. And for those of you who know about eChild, we will be reusing the health to education link that eChild set up. So those are my colleagues, Ruth Gilbert and Katie Haram at UCL. And then to look at sort of being able to take into account maternal health as well, we will be linking to maternity services data, which is a relatively new data set. It's about 10 years old now in England, and then linked to maternal hospital records up to a year before the child was born. And then children born around the time of the 2011 and 2021 census, their maternal census records will also be linked to the cohort. So there's like health data, so and education data. So how are we going to link in the environmental data? So for the first time sort of nationally in England, as far as I'm aware, We are planning to link the children to their longitudinal address histories from the Personal Demographic Service, which is like the I don't know what it's called in Wales, but it's the sort of national English NHS address records, and we will be they will be linked. These address histories will be linked by ONS to unique property reference numbers. So it will be possible then to link environmental data at the specific address where the child has lived over time, and the children's mothers, we will also link to their addresses up to a year before the child was born. And then we will have information on school locations. So that's a huge interest for us at the moment. So looking at school indoor and outdoor environments around schools, so they'll be able to be linked to the cohort via longitudinal school locations, which is available from the Department for Education. So a lot of data, which is great. And these are the environmental data that we're planning to link as part of setting up the postcode. So they are energy performance certificates, which tell you about well, the energy performance of and other things about the sort of private property. So, for example, does the property have central heating, access to gas main, UPVC windows, like what type of windows and things like that, floor area. We'll also be linking to valuation office agency data that I know you've been working on in Wales as well. So that's tax records. That also holds information about number of rooms, etc. in the property. We're linked to DEFRA air pollution data, distance to road data from the Ordnance Survey, green space data from the Ordnance Survey. And then we have developed, because we're particularly interested in childminders, given this massive decline in the number of childcare provision. So we are linking to availability of, we're developing a data set of how close distances to sort of Ofsted registered childcare providers in England. So this is what we're providing. Most of these, apart from valuation office agency data, they are not under license, which we're focusing on being able to provide data sets that come under open government licenses. But we totally understand that researchers may want to link in their own environmental data, and so the approvals will be there for researchers to apply to ONS to do that, and they would then need to provide their UPRN mapped environmental data to ONS, and then those will be encrypted, and it will be possible for researchers to link the data within the ONS trusted research environment using encrypted UPRNs. So the Kids Environment and Health Cohort will be available in an ONS, Office for National Statistics trusted research environment. And so this is how we've got so far. What we've got so far, we have ethics committee approval from both NHS and National Statisticians Data Ethics Committee, and we have approval from the Confidentiality Advisory Group, which gives us a legal basis for linking the data. We're having a long and interesting journey of our data applications with NHS England and the Department for Education. However, ONS have completed the spine linkage, and they're currently working on linking the census to the spine. And we have we are currently, as we speak, I think, uploading the first environmental data to be linked to the birth records using UPRNs. We have pretty much completed a study looking at these nursery locations that we've mapped, because as it turns out, it's very difficult to know where Ofsted registered childminders are. There's no geolocation on the Ofsted data, so we've spent a lot of time doing that. And we've just completed a paper looking at air pollution levels around nursery locations in England. And I'll tell you a bit more about public engagement. We've done a lot of public engagement, but at the moment, the phase 1 of the cohort, which will be ONS-derived data linked to environmental data, will be available to approved researchers in the ONS Secure Research Service, I think at the moment, in late 2025. And so we have done a huge amount of public involvement and engagement for this project. That's a priority for both Administrative Data Research UK and Health Data Research UK. And we've done a lot of work, as I said, with the Young Persons Advisory Group at Great Ormond Street Hospital, but we've also worked with Generation R in Liverpool, which is a Young Persons Advisory Group as well. And we worked with the Parents and Carers Group at Great Ormond Street Hospital, and we worked with a number of charities, such as Mums for Lungs, Mothers Rise Up, and Space for Girls. And we have 3 parents on our study advisory group. We've also done a lot of engagement events. So here is an engagement event, which was a street party at Great Ormond Street, where I met like the Star Wars, if there are any Star Wars fans, I met stormtroopers and Darth Vader and stuff. And we've also developed some teaching materials for Key Stage 2 in primary schools. So it's a teaching resource. It's like a 20-minute talk to teach children about epidemiology and how we use data and things like a correlation versus causation and things like that. And we've used these in a number of schools around South East London in collaboration with Mums for Lungs. And we've also done a number of talks to older children as well who are doing their A-levels. And I've also written a blog about our public engagement journey on the ADR UK website if you're interested. So we're really pleased because we've had a lot of interest already from researchers who want to use this cohort, and we are really, really delighted that we've been able to get funding working. Well, I have been able to, really Swansea and Rich Fry has been able to get funding for a project called Magenta, which stands for Maternal and Pregnancy Health and Elevated Heat, and it's looking at it's led from Swansea, but we are one of the other centres, and it's looking at how exposure to elevated or prolonged heat during pregnancy impacts pregnancy outcomes in Wales and in London. So this study has now started, and I'm not going to go into it in a lot of detail because I don't have much time because I've been talking too much. But there are a number of work packages. One is looking at deriving the environmental data and indicators for urban heat, for heat exposure, including urban heat islands. Work package 2 is the one that we will be working on from UCL. And that's looking at using administrative data to look at the impact of heat exposure in pregnancy on birth outcomes using SAIL and in Wales and Kids Environment Health cohort for London. And work package 3 is will recruit a cohort of pregnant women in Wales to measure like physiological responses and physiological stress during periods of heat. And then work package 4, sorry, it should say 4 there, is led by Rhiannon Owen, again at Swansea, and it's all about putting these data together to forecast future trends and how maternal and perinatal health will be impacted by extreme heat due to climate change. So we're really excited to be working with you in Swansea on this. And that's all I was going to say. I think I probably talked for too long, but this is information about the Kids Environment Health cohort and our website. We're trying to do a lot of engagement on social media, particularly Instagram, because that's what parents told us they wanted. And here is our link to the Environmental Child Health Research Group and our new logo, and you can read about all the projects we're doing there. So thanks again for inviting me. I'm really happy to take questions.
Thanks very, very much. That was fantastic. So thank you. Ting, please go ahead with your...
Thank you, Pia. This is fantastic, and I mean, really excited to know this children's environment and health cohort, which is, I mean, from many angles, it's such important to look at the whole children development and how the environment factors have been affecting the whole development process. And I'm wondering that, although you mentioned that this is currently more focusing on England, I'm wondering whether you might consider to expand it to Scotland as well. And the reason why I ask that is because for the winter respiratory pressure work, we are also looking at whether we can get access to the environmental data because of the seasonality of respiratory diseases, and we want to understand whether the environmental data will be able to help us to predict the seasonality or circulation of the common respiratory infections during the wintertime period. So we are very keen to look at the environment data here for children population. And anyway, I'm just trying to understand whether you might have a plan to expand your research to Scotland as well.
Yeah, I think that's a great question, because when I put in the grant several years ago now. I did speak to Chris Dibben about this, but we felt that we couldn't do it because the way that Scottish, or the PBPP and Idris work would mean that it's not possible for it to work in this same way that we're setting it up, so that they're very much sort of project based, whereas this is kind of setting up a linked research resource to then be used by a lot of other researchers, and that wasn't at the time anyway possible in Scotland because of the way that approvals work there. So no, I can't say that I'm doing that. As you know, there is, the WHO believes that they state that the association between PM 2.5, fine particulate matter air pollution, and sort of there's a short-term association, link between that and respiratory admission, which is causal. So I think you should definitely include that, but I wouldn't. We're not going to focus on Scotland because just I'm telling you, trying to get England going is a real issue. We are doing work, so I also led something called the picnic study where we're writing up the papers now. We are doing one paper, kind of going back to what you were talking about before, looking at children who've been admitted to hospital with bronchiolitis, and then seeing whether air pollution affects their risk of developing asthma using Scottish data. But for this, we are just trying to get it running for England. Is a lot of work. So, but yeah, I have had those conversations, but yeah, not at the moment.
Thank you. It's already very impressive in running in England with such massive data, and be very keen to have another conversation, because potentially we'll be looking at the similar research question in England's databases as well. So thank you.
That's great. Yeah, it'd be great.
So Pia, to tie up the talk from last week where we presented Merida, right? I would be very enthusiastic about talking to you, and there is Born in Scotland, about within Merida us trying to do things that you think are worthwhile and linking these databases if they're available, and to see if that helps to validate or do things. And so that could involve Scotland, Wales, and places in England, if that was useful to you and helpful to you.
No, that would be great. We're very keen to talk and to have people use these data. So just to say, we are the data won't be available for probably another year now, and there are some challenges with getting linkage to health data in England at the moment, with both ADR and HDR working on, but we are working really hard and trying everything to get the data going. But there will be some data available because we are going to use it for Magenta. But yeah, I'd love to talk to anyone who's interested in using this.
Abu, please go ahead.
Thank you very much. I had a very nice presentation, and this is just extension of Ting's question. Do you have in mind to work in other countries? Because I'm coming from Sri Lanka, the children, suffering from multiple other things. Than here is you have enough facilities. Also, we have some other problems, but we can correlate other diseases, but we have issues with the data that not quickly available in the soft format, but in the hard format. But you can work. But if you have an idea, I would like to extend my invitation to that. Thank you.
Oh, lovely. No, I totally agree. Yeah, so we, air pollution and pollution and climate change, biodiversity loss is a global problem. So we're really keen to sort of work with, other countries' data as well. I've done work in Canada and Sweden, and we're speaking to people from Brazil and CDAX at the moment as well, trying to get some collaborations going there. But yeah, we're really keen to work with others, so please get in touch. And there's a number of other people in the team who've worked in a number of other countries as well, including in Texas and the US, which has got some, as you can imagine, quite interesting environmental disasters and stuff like that.
Let us know how to interact with you and get, analyze and get your insight, how to do that.
No, please do get in touch. Yeah.
I have a question for you, Pia. You're from Sweden, right? Mm-hmm. Is there anything Sweden are doing that we should be doing here to protect children? Is there any insights you think were?
I was in Sweden just last week. Sweden is a very different country, and it's got a totally different history. So in terms of the social environment, the childcare stuff we're talking about is you pay £100 a month or something for childcare full time and things like that. So it's just the way that children are valued is completely different, starting from maternity care sort of upwards. So there's obviously that. In terms of sort of more environmental aspects, I mean, there's far more sort of just the way that Sweden was an incredibly poor country for many years until the Second World War. So the way that cities were planned is much more modern as well. So there's a lot more greenery. There's far less sort of even in Stockholm, there's sort of the city centre's quite old, and the rest is built in the 30s and later. So there's far more sort of planning and having green spaces between buildings, not building too much, etc. It's a massive question, Sinead.
Yeah, no, but I mean, that's the thing about, because climate change is a big thing, and needs a big picture thinking, So, there are countries that do this well, and Sweden's one of them. So what is it that going forward, like, is it green space, valuing green space? Is it valuing children? What is it that you think needs?
I mean, I think the valuing children and valuing families is key, and that goes from sort of anything from sort of like I said, social services, for universal services for all families. So I think that's one aspect. But children, I don't think so. I think people have this view like Sweden and Scandinavia, so they're totally different countries and all of that, and then they are, and they've had a very different history. But there's nothing, I don't think, that would, like Michael Marmot would say, that these are just policy differences. There's nothing that they do in Sweden that we couldn't do here if we really wanted to. You could tax petrol a lot higher. You could invest a lot more in insulating houses, in the amount of we were talking about schools earlier, the underfunding of school repairs and converting schools to net zero and things like that is just shocking. So I think those are policy differences, and we could tackle those tomorrow if we really wanted to, but I don't think there is a political will. That would be my take. I don't want to
what do other people think? It's sort of as a group, as HDR UK group, what are the things that we think can be focused on, evaluated here to help steer a direction that is about improving respiratory health, inflammatory, reducing? What do people think?
I think there are a number of... Oh, sorry, Gwyneth, I was going to say something.
No, you go ahead, Pia, because I was just going to say I can't really say it better than what you've just said, really. Obviously focusing on reducing pollution levels and protecting particularly vulnerable groups, including children, and clearly, the green spaces and value of children. But it's a really important point how we can learn from, countries that are doing it much better than we are.
What are we going to say there, Pia?
No, I agree. I think there is a I still think there is this, well, we couldn't do that because we're the UK, or that's not, there's no I think Mexico City used to be one of the most polluted cities in the world, but they've really had mayors, I think, who've really sort of pushed and trying to bring pollution down, and it's been very successful. So in terms of sort of air pollution, that it is going down, it's not getting worse, it's just that it could go down a lot quicker. But there's the ULEZ in London, there's been one in Bradford that are being evaluated. The convert, trying to move to electric vehicles, which will bring down air pollution. There's various things that one could do to sort of, the green spaces would really sort of mitigate heat exposure and things like that. So I think we can really support in, I feel it's very easy to feel sort of depressed and sad, but I feel like, my role as an epidemiologist is to bring the data, because you can't argue with, well, you can argue a bit, but I think we're all keen on robust methods and things. But so, Anyway, that's how I feel. Sorry, it all got a bit philosophical.
No, but that's we want a bit of a debate, really. So Sam, go ahead.
Really fascinating presentations. Thank you very much. And Pia mentioned the Magenta project, which I'm working on, and it was just a general comment, kind of reflecting on the last couple of days as well. And in Magenta, one of the things we're doing is we're going to be forecasting the impacts in different climate scenarios. And I guess that's quite a new thing for us to kind of be getting involved in. I think that will be a key thing, is kind of showing that where we're heading to, essentially, and the importance of these kind of interventions. And I think that's going to be the difficulty over the next kind of couple of decades, is kind of raising that kind of priority when you've got all conflicting issues. But that'll be interesting as we kind of build our expertise in forecasting. I think that'll be really key. That's just a general comment. Thank you.
I was just going to say, there is now an international group that are trying to attribute various. So, for example, that I think it was from Valencia now. They were saying that they're able to use data to try and attribute it to climate change rather than to the man-made climate change, human-made climate change. So yeah, I think that's a really interesting to not being able to argue and say, oh no, it's just a chance event. I think that's a really nice initiative, actually.
Yeah. So thanks so much, Ting and Pia, for your really fantastic thoughts and talks. And thanks very much, everybody, for coming. And hope to see you again next month. Thanks very much. See you.